guys. Looks like we got a pretty good contingent now. Thought we might get started. First time doing this on Zoom. Look, I think it actually might be a really good opportunity to, when I run the tube normally, I'm just asking people lots of questions through the whole thing. But I reckon we can really do that here as well, with the advantage that essentially I can get everyone to either speak out their answers or write down their answers during the session, and just try to get it as I guess we're trying to practice as much active recall as possible. I mean, this exam is a small part about detail, but a really large part about just communicating what you know and just being really familiar with your words and your expression of the content as well. So let's get started. At any time, just please put your hand up on the screen, or just unmute yourselves and ask whatever you need. So essentially, structure my teach, lots of questions, SAQ practice, Viva answers. So yeah, make sure you have a pen and paper ready. Lots of classifying, definitions, and diagrams. I sent around a file, like a classifying exercise for the different respiratory topics. And this is something you guys can just do in your own time. And feel free to send it to me. When you send it to me, I'll send you my classification that I've done for the answers. What I found that really useful for was, like, say you have a short answer question, for example, or even in the Viva, and the topic is FRC. When you've already practiced those different categories of your answer for FRC or for whatever topic it is, and that's part of you've blocked that as part of your memory. I just found that really useful and stopped any waffling of my answer. It really helped me to structure the answer. So each category, each class, each part of the answer would then be on a different page or half a page of the examination booklet as well, which I found really useful. I will go through definitions. And I also sent around just a list of pretty much all the diagrams that are in the respiratory syllabus. And one of the things that I found really useful was, sometimes if I'm in theatre, I just copy these diagrams. Clearly, great use of theatre time. I mean, especially in a long case, you can get so much done, especially things that are a bit more passive and don't require that much involvement from yourself. So just practicing drawing the diagrams, and I wouldn't just draw them exactly as they were from the textbook, but I'd layer them. So I'd get very used to drawing them in the most efficient way. What are the most important pieces of information? What are the important values on the y-axis and the x-axis? What's the minimum amount I can draw to get my point across? And so I'd have different layers of, potentially what the examiner might ask of me. So yep, definitely have your diagrams ready for cardiac, neuro, respiratory, and even renal. Okay, by the end of these 3 tutes, hopefully you'll have a set of notes that have covered everything, and really there's nothing else that will be asked on this exam. I can't guarantee that. Layer the knowledge. So we're going to try and when we do like short answer practice, we're going to try and go through a 3-minute question, a 5-minute question. Like knowing how to layer your answers is I think is really essential. So knowing that a framework itself can get you close to a pass. A framework plus a little bit more can probably get you a pass, and then adding more detail can be beneficial as well. And hopefully we'll go through some detail to answer the harder questions and guarantee the pass mark and gain understanding. Yep, as I mentioned, SAQs and Viva style questioning. So I will, at the end of each series of lectures, I'll send you all the lecture notes from this session, and I'll send you the objectives for the next one. Sorry, I may have forgotten to send you the objectives for this session, but this is essentially all the topics that we will go through. Okay, so as a first exercise, so this is, I don't think this has ever really been examined, but it is part of the syllabus. So what I'm going to get you guys to do, just literally imagine getting the question, describe the structure of the chest wall. Siak, do you want to have a go at this?
Yeah, so I split it into location, composition, purpose, and special groups potentially. So location, I just said thorax between the abdomen and the cervical vertebra, composition, bone, cartilage, muscle, skin, subgut fat, fibrous tissue. And then you can sort of break it down in regards to that. So you can talk about ribs, sternum, manubrium. I'm not sure if the clavicle is part of it, but then you can talk about muscles, so intercostal muscles ×3. And then you can talk about the purpose. So it contributes to chest wall compliance, it protects the lungs and the heart, contributes to active and passive breathing. And then you can talk about potentially special groups. So for instance, with increasing age, you get scarring and decreasing decreasing chest wall compliance. You can talk about neonates who have increased rather chest wall compliance. So yeah, that's sort of the thoughts that I have.
Excellent. Thanks, Yak. And just to know, so you went through really systematically. You described where it is, what it's formed by, and there's no secret to this. If you just imagine your own chest and the layers, you can get all manner of answers from and good content from preparing absolutely nothing. And that's almost the reason why I start with this question, because it's often a question that many people haven't really prepared for at all. But you can get so much down with little actual reading for this topic. So I thought that was really good assessment of that. Let's do this again so that's just what I've written here. What you said. How about the structure of the diaphragm, structure and function of the diaphragm? So take a couple of minutes for this, and I've just given you a few headings there just to work through. So take a couple of minutes and raise your hand when you finish doing this. I want you to time it as well. If you have a timer, try to get as much down as you can in 2 minutes, starting now. Kieran, Rowan, do you want to have a go at this one?
So I basically tried to stick to the structure that you have there.
Yep.
I put that the diaphragm is a dome-shaped muscular structure that separates the thorax and the abdominal cavities.
That's good.
When you put the level depends on, I wasn't entirely sure what you were getting at, but I thought that was pertaining to the position of the patient, the intrathoracic pressure and the intra-abdominal pressures.
Mm-hmm.
The nerve supply is from the phrenic nerve, which comes from...
One more thing they mentioned in on respiration as well, and they mentioned the abdominal organs, causing the right dome being higher. But anyway, keep going.
The nervous supply, it is innervated by the phrenic nerve, which is supplied by the C3, C4, and C5 cervical nerve roots. And the apertures are the esophageal hiatus, the aortic hiatus, and then I think there is one more that I couldn't quite remember.
What's the other big vessel?
It'll be the inferior vena cava, so it'll be the caval hiatus.
Correct. This is an interesting one. We all learn about C3, 4, 5, keep the diaphragm alive. So motor supply. What do you reckon the sensory supply of the diaphragm is?
Sensory supply. I thought, is sensory supply not the same?
Yeah, it is the same. So partly it's C3, 4, 5. And then the other thing, if you're not really sure about, there's actually another sensory supply to the diaphragm. What else would supply it if it is in the region? As long as you're geographically close to the region, that's probably the supply to it. So what do you reckon?
I imagine it's from from some thoracic, has some thoracic innervation as well.
Beautiful. So just from logic, you've got that. So it's the C3, 4, 5 plus thoracic nerves T5 to T11. That's good. The apertures you're absolutely correct about. What's interesting? Do you have any interesting facts about the apertures?
Not that I can recall. I can't quite remember.
No, that's right. So this is one of those really interesting things that when the diaphragm contracts, that would essentially be what's the problem if the diaphragm contracts to the vena cava?
So the vena cava is a low pressure vessel. So as it contracts, it might compress the vena cava and reduce venous return. And
that's not really what happens, is it? You take a breath and you get increased venous return in that moment, where you've got a negative intrathoracic pressure. So there's something about this diaphragm, and I found this really interesting. There's something interesting about the way that the fibers are arranged. If you contract, they're arranged such that the aperture, the cable aperture, doesn't constrict. It actually widens the opening.
Okay.
So that's interesting. How about the esophagus? What would happen, if you were to inspire with your esophageal aperture? What's one of the things that could happen?
I suppose if the fibers are orientated the same way that they are with the inferior vena cava, then you could actually decrease the pressure on the lower esophageal sphincter, and you could get reflux and regurgitation of stomach contents.
Exactly, but it's arranged quite amazing. So if, in an ideal situation, what would you want to happen on inspiration?
You'd want the opposite thing to happen with the inferior vena cava. So you'd want contraction at the lower esophageal sphincter and relaxation or opening at the hiatus where the inferior vena cava passes through.
Yeah, so you get contraction. Inspiration causes restriction or contraction of the fibers around the esophageal sphincter, and thereby minimizes the chance of reflux. Yeah, so that's exactly everything that you think should happen happens with the diaphragm, through those openings, and the aortic opening does not pierce the diaphragm, so blood flow is not affected at all with that. Very good. Let's go on to the next section. So yeah, function, main muscle involved in respiration, venous return, and anti-reflux as well are the three functions there. Okay, so in outlining the anatomy of the airways, I'm going to just put out all these questions, and I want you guys to all have a go at just answering this. Yeah, just speak out loud. Just have a go at answering these questions. So take a minute. Speak out loud to yourselves. I just want you to know what you know and know what you don't know, and just really embrace that. Okay, so have a go at answering this. Imagine a survivor. What is the main function of the airway? What are some interesting properties of blood-gas interface? What about the airways? Where is the conducting zone, respiratory zone? How many divisions? Obviously, I've given you a diagram as a hint on the side. What's the anatomical unit of the lung? Define it. What's the method of gas flow? And where does dust settle? Maria, what do you reckon? What's the main function of the lungs, of the airways?
Can you hear me well there?
Yeah, all good.
So again, well, they're going to have the way I divided it, respiratory and non-respiratory functions, but I guess for the airway, the main function is essentially conduct air from the atmosphere to the alveoli, and then conduct oxygen from the alveoli to the blood, and CO2 from the blood to the alveoli. But essentially, if we're talking only about the conductive airways, it's mainly conduct air from the or gases from the atmosphere to the alveoli.
Great, and I'd say, yep, its main function is gas exchange, oxygen delivery, yep. CO2 elimination. Fantastic. What are some interesting properties of the blood-gas interface?
So I think the main thing is the fact that it's going to be a very thin layer. So that's going to be ideal for gas exchange, as we said. Yep. And also, yeah, that the surface area is quite extensive, and that facilitates gas exchange as well.
Fantastic. Do you have any numbers for how thin and how big the surface area is?
Yeah, I think the surface area is approximately 50 to 100 square meters or something like that in an average adult. And in terms of how thin, I think it's something like 200 nanometers or something like that. I can't quite remember that one.
0.3 micrometers is what's written in West. So yeah, extremely thin.
Yeah.
You know, there's certain figures that seem to be kind of asked, and I feel like those two are a couple of figures that it seems to be a thing that examiners will ask these kind of numbers. But if you couldn't remember and were to give a rough guide, that sounds pretty good. So obviously you can see what the conducting zone is, the respiratory zone. So the respiratory zone is anywhere beyond the terminal bronchioles, so from the respiratory bronchioles, any area that actually has alveoli there. And you can see how many divisions there are, which it's not something I'm going to care too much about remembering. Maria, what is the anatomical unit of the lung?
So Yeah, so it's present in the respiratory transitional respiratory zone, and it's composed from the alveolar sac, alveolar sacs, and the pulmonary capillary, where the exchange of gas occurs. Is that the one?
So what was the anatomical unit? This is one of those, you know, every organ itself has a anatomical unit, you know, that they seem to define. Where does each anatomical unit of the lung start from, and what is it called?
I don't know.
That's right. So it's the acinus, and it's the portion distal to that terminal bronchiole, and that in itself, that unit there is in itself an anatomical unit of the lung.
Yeah.
What is the method of gas flow?
So the method, is that, you mean where, like how it occurs, or? Yeah.
So again, there's kind of so go on.
Yeah, well, I'm thinking about, is mainly done by diffusion. Is that what you mean? So that it occurs by diffusion, Fick's law?
It does. That's part of the answer. So it occurs because of diffusion after a certain point, but before that point, how is oxygen getting into the end zone of the lung?
Yeah, so I guess there has to be a pressure gradient.
Yes.
That facilitates the transport of oxygen, and maintaining that concentration gradient, the oxygen will diffuse freely from the alveoli to the pulmonary blood. Okay,
good. So I just want to clarify that then. So imagine the reason we can initially get oxygen from the atmosphere into the lungs is by inspiring. You have a relative negative pressure in your lungs, and you get bulk flow of movement of gas from the atmosphere into your lungs. But at a certain point, the flow is at such a low level. So imagine that in the first part of your lungs, the trachea, the bronchi, the bronchioles, or the upper bronchioles, the surface area of all of those structures isn't really great. So that area is moving through bulk flow due to the negative pressure. But once you get past the terminal bronchiole, there's so much surface area, there's so much volume that can occur there, that bulk flow is no longer the reason that you have flow. So past the terminal bronchioles, it's purely diffusion. Does that make sense?
Yeah.
And this is really interesting. That leads to the next question. So because of that, the fact that there's no more bulk flow promoting this, gas to move through this, pressure gradient, that's exactly where dust settles, which is quite an ideal thing if you imagine that. You don't want dust and other particles being, through negative pressure being thrust into your anatomical unit, your respiratory zone. And so it will all deposit, hopefully, where bulk flow ends, which is at the terminal bronchiole. So kind of an ideal situation for gas exchange in your lungs health.
Yep.
Okay, so I thought I'd go through this again. Pretty esoteric topic. I don't think it's ever really been examined, but blood vessel and flow. So pulmonary blood vessels. So just thinking about this, outline the anatomy of the pulmonary and bronchial circulations. And so actually, why don't you guys have a go now? Again, take a minute, just have a read of that. This is straight from West, I guess the most interesting facts that I could, that I really tried to get to memory about the pulmonary and bronchial circulations. And I want you to have a go at just answering the questions of, what's the diameter of the resistance? Relatively speaking, what is the resistance? What's the time of the RBC in the capillary network? And also, what does the bronchial circulation do? Thomas, what do you reckon?
Yep. So just answering the diameter resistance questions, is this right?
Yep, that's right.
Okay. So diameter, I'm not too sure. I would make the assumption that the diameter is somewhat similar to that of systemic circulation capillaries.
Yeah, just give me a value. I mean, it's not the biggest deal.
Oh, No idea.
10 micrometers is what they've got.
10 micrometers. Okay. Resistance. So the pulmonary circulation is defined as a low resistance circuit.
That's good.
I think from memory, is it 16 dynes is the value?
I can't actually remember, but that sounds about right.
Yeah. And red blood cell timing capillary network is defined as 0.75 seconds typically.
Yep, sounds good.
What does the bronchial circulation do? So the bronchial circulation is the delivery of blood to supporting tissue of the lungs, so not involved in gas exchange, and so it therefore is defined as a shunt per se. How much flow compared to pulmonary circulation? So usually it's about, I think they say it's like 0.1%, but in COPD it can contribute up to sort of, I think they say 90% of shunt. Blood flow to.
I don't know that figure, but if you're happy with that, that sounds all right.
And can you function without it? I'd say no. I think that it means that you would not be providing blood to your support functions of the lungs.
Actually, so the example here is, think of a lung transplant.
Ah, okay.
So, yeah, you can survive without it. And it simply, in the lung transplant, you don't transplant the bronchial circulation at all. And so, yeah, you are able to. Yeah, bronchial circulation supplies conducting airways down to about the terminal bronchioles. But, yeah, that's good.
Cool.
Next slide. Okay, so this is for this question. So describe the neural and chemical control of ventilation via the central and peripheral chemoreceptors and indicate how this is altered by anesthesia and abnormal clinical states. Thomas, while you're there, what kind of when are you sitting exam, Tom?
So I've sat the written, so I'm waiting for the vivas in October.
Yeah, sounds good. What structure would you use for this question?
So I'd probably talk about peripheral, I don't know, I mean, it's kind of already classified in terms of central and peripheral chemoreceptors. So I'd talk about CO2 and then O2 and then they'd be the major ones.
The question just below it, sorry. List the physiological factors that increase rest rate.
Oh, sorry.
Brief
I
explanation.
misread it. Physiological factors that increase respiratory rate. Give a brief explanation of the mechanism. So I'd talk about, I think I'd talk about it in terms of a loop. So I'd talk about the controller. So the respiratory center, so of the dorsal respiratory group and the ventral respiratory group, and how they determine your pattern. I'd talk about sort of inputs to that. So your CO2 at peripheral and central chemoreceptors and the effect of hypoxia on the, I think O2 is peripheral chemoreceptors, I've forgotten. And then you've also got, I'd define it as sort of other factors for all the other non-specific stuff. So
sounds good.
Muscle movement, running, sort of emotional and sort of amygdalal inputs as well.
Hi, Millie. I'm just going to go down the list. Can you tell me about the central controller? Hopefully you guys have got a few notes down there in the last 5 minutes or so.
Sorry, this is going to be very bad.
Hey, bad is good. Bad now is better than bad later, right? So
Okay.
just give me some true facts about, whatever you know.
So ventilation is primarily controlled by carbon dioxide. pH also controls respiration as well. The medulla is the primary respiratory control center. And
yeah, good.
Yeah,
That's good.
essentially the only abnormal clinical state I can think of is in something like COPD, where you lose the hypercapnic respiratory drive.
Yeah, good. So you had a bit from central, in terms of sensors, you had a bit from there, and you highlighted the good thing is the first thing you said was CO2. So that is probably the most important sensor from, on a day-to-day basis. So that's really good. After that, you'd say probably oxygen and then pH, then other, and we'll go into that. In terms of central control, again, you hit the nail on the head that the medullary respiratory center is, the most important part of that. There's two areas, the dorsal respiratory group and the ventral respiratory group. And I'll just go open that up there. So the central controller, periodic nature of respiration controlled by the neurons in the pons and medulla, the respiratory centers. And you've got these various respiratory centers. I've just got here straight from Westler. So inspiratory area has intrinsic periodic firing. It's a latent period followed by crescendo action potentials, which increase inspiratory activity in a ramp type pattern. I don't think this is too important to get all of this detail, but importantly knowing where the centers are, what's the most important center, and then the fact that there are other centers there that have certain tasks. So at a very baseline level, knowing about the dorsal respiratory group and ventral respiratory groups would be very, very important. And then the effectors, again, pretty easy. It's the phrenic nerve leading to the all the respiratory muscles, which include the diaphragm, the intercostal muscles, the accessory muscles, and the abdominal muscles. So I might get, so let's say that these are, the chemical factors are probably the most important involuntary factors. You can definitely increase your respiratory rate, voluntarily through cortical control. That's, only for a brief period of time, really. Why don't you guys actually, so do anyone have much information down for the detail for CO2?
I guess I had a little bit down. I can give it a crack.
Yeah, go for it.
So
Who's that, sorry?
It's Hamish, sorry.
Excellent, go for it, Hamish.
So hypercapnia is detected by the central chemoreceptors, which sense PaCO2 indirectly via detecting the pH of the surrounding CSF.
Yes.
So CO2 dissolves across the, CO2 dissociates into H2CO3, which then becomes hydrogen and bicarb in the CSF. It's a very sensitive system with a very acute change in respiratory rate and tidal volume by directly stimulating the medullary respiratory center. And the response is blunted by anesthetics agents. So you get a rightward shift of the curve requiring a higher CO2, so a lower pH to get the equivalent response.
Excellent, excellent. So a lot of good facts. So, one of the interesting things that you correctly mentioned was that it actually changes in response to the pH change caused by altered CO2. So, I thought that was really interesting. I've definitely had examiners kind of ask me more about that. What is important about the CSF that allows for this really quick change?
I'm not sure specifically, but does it not have a lot of buffers to pH change? Is that and a
That's
low
exactly
volume?
right. And I like the way you work through that, right? So if the pH changes quickly, it's because it doesn't have what the rest of the body has, right? Normally our pH doesn't change that much because we have multiple buffering systems. So specifically the CSF, shouldn't have a lot of protein, and that's why it, changes, remarkably for the same, change in hydrogen ions. So that's good. Yeah, less protein equals less buffering capacity, so greater change. Good, and then I've just got here peak effect by 1 minute and wanes in hours due to normalization of CSF pH by the movement of HCO3. So ultimately, after in minutes to hours, you get a shift of HCO3 to then buffer that change slowly. Do you know much about, Hamish, the peripheral chemoreceptors and its involvement in this?
A little bit. So the peripheral chemoreceptors are in the carotid and aortic bodies. I think the carotid bodies are more sensitive to hypoxemia, much more so than the aortic. They have a very high blood flow compared to their metabolic rate, so very low oxygen consumption, and so can detect changes in PaO2, and their response is heavily blunted by inhalational anesthetics at very low minimum alveolar concentrations. And that response, I think, as well, is enhanced by acidemia and hypercapnia. Is that right?
There is a combined effect from the other things. I'll show you some graphs of that as well. So yeah, I think you're correct about that. So yeah, every time I look at this, I go, you know, what's different? What's interesting about these peripheral chemoreceptors versus the other stuff? And I think you mentioned some stuff correctly. They've got a really, really high blood flow. You know, relatively high blood flow of what, 2,000 mils per 100 gram per minute versus cerebral blood flow, which is considered very high, which is 55 mils per 100 gram per minute. So that's obviously a really interesting and important fact, and something you can easily remember because it's so far ahead of any other organ blood flow, and the response is, you know, really sensitive. So, you know, increasing 2 to 3 liters per minute for every 1 millimeter mercury rise in the PaCO2. So that's, you know, two really, really fascinating or really, you know, interesting points about the peripheral chemoreceptors as opposed to central ones. That's good. So, and if you were to draw a graph, this is, I think this is what you're talking about. You've got, you know, this, can everyone see my arrow there?
Yes.
Yeah, excellent, good. So essentially, you know, you've got your typical values as your alveolar PCO2 rises. Actually, let's get someone to talk about this. Yeah, Hamish, do you want to just explain this graph for me?
Let me have a look.
And actually, what I'm going to get you to do, so I'm going to get you guys to talk through a number of different graphs, and this is probably, you know, some of they'll all be varying levels of difficulty and familiarity. I want you to use the same format for each. So I want you to start by just saying true stuff about the graph. You know, what are the things that you see that you really can't get wrong? And just imagine like later on, there'll be a pretty unfamiliar graph to most people that I'll put up. I want whoever's answering it to, you know, use that format of just tell me true statements. You know, I know back in med school, you'll be given a chest x-ray and you get points for saying this is a chest x-ray of this person on this date, you know, and then just going through some obvious stuff like, you know, I can see these structures. I kind of want you to do that with these, with the graphs as well, just to get true answers on the page, getting answers to the examiner, and without getting stuck. So that said, go for it, Hamish.
Okay, so this is a graph which shows, demonstrates the change in ventilation at different alveolar PCO2s, with 3 different regressions corresponding to various alveolar PO2s. The graph demonstrates a synergistic effect, so that at a lower alveolar PO2, the response in ventilation to alveolar PCO2 is much steeper and more rapid. And as alveolar PO2 increases up to 110, the response to ventilation to PCO2 becomes less steep and at a requiring a higher PCO2 to get the same change in ventilation.
Yeah, I think that sounded all fine. Yep, so this is a graph of the change in ventilation in liters per minute as the alveolar PCO2 rises. What's notable is that, you know, there's three graphs, each with a differing alveolar PO2, and a decreasing PO2 increases the rise of ventilation for any given CO2, which is pretty much what you said. Okay. Who wants to have a go just giving me a few points for a few, you know, facts about PaO2 control of ventilation?
I can try.
Go for it. Thanks, Alice. Go for it.
So I guess partial pressure of oxygen can impact your respiratory rate predominantly via the peripheral chemoreceptors.
Mm-hmm.
And I think it's that they don't actually respond until the oxygen is below 60 millimeters of mercury, which would make sense.
So do they have any firing at all?
I didn't think so until it reaches that point.
Yeah, so there's firing at even 500. It begins at 500, but there's very little response until what you've said.
Oh, right. Okay, cool.
Keep going.
And as already mentioned, that's transmitted to the central controller via the aortic and carotid bodies, aortic by vagus and carotid by glossopharyngeal. Essentially, the central chemoreceptors don't respond to a change in oxygen partial pressure. And the peripheral chemoreceptors are much faster response. Oh, sorry. Yeah, I think it's that they're a faster response, but they're only 20% of the control of ventilation or something in comparison to central chemoreceptors.
Exactly, yeah, very fast response, but less important than the central response, correct?
And essentially, obviously, I can't remember. I think I can remember the graph.
So that's right. And just one more thing: the response is more important at altitude, obviously, and chronic lung disease. So, you know, if it's only really firing, you know, in an appreciable amount below 50 millimeters mercury, then it's only going to really be important for those circumstances that we have very low PO2. So, do you want to describe this graph for me?
Yeah, that was the one. So it's this is a graph displaying the change in ventilation for a change in arterial partial pressure of oxygen. Is that what you've written? What does it say on the side there? Something maximal responses? Yeah,
maximal response. So, and here's a really good tip. If you have to draw a graph and you don't know what the units are, as you can see from this graph, it seems fair game to just go percent of maximal response. A bit of a cop out, but you know, helps to prove a point, really. Okay, keep going.
So I guess the point of this graph is to suggest that, as we were saying, it's going to have minimal firing from anywhere from 500 down to approximately 60. Then at 60 millimeters of mercury, the response in ventilation will increase drastically as the partial pressure of oxygen decreases.
Sounds good. And so I want you to tell me, so for pH, I've just got here, carotid bodies and not aortic bodies, respiratory and medical acidosis, and also interaction of stimuli occur. So, you know, the main parts of this, of the sensor, the main content here really is in PO2 and PCO2 responses. Can you talk to me, Alex, about the integrated responses in the graph below?
Yeah, so essentially that graph, I kind of find this a bit confusing. I was looking at this the other day, but it's essentially looking at what we've just discussed, so the arterial partial pressure of oxygen and the change in ventilation in response to this, but it's looking at the integration between partial pressure of carbon dioxide and oxygen and this, I guess, synergistic response of minute ventilation. So essentially I think it's, essentially there's not much change for the majority of partial pressures of carbon dioxide, so like 35 to, oh, actually, wait, maybe I'm getting confused now. I just remember that essentially they both are obviously going to impact your minute ventilation, but I'm not really sure how to explain the different levels of CO2 there.
Yeah, I mean, you can really just tell me what you see. I think you know the answer because everything you've said is correct. And right now, so I mean, what is that 35.8, 43.7, and 48.7? What are those values?
So that's the partial pressure of carbon dioxide.
Fantastic. So now you can literally describe for me each of the different curves and say what is the difference in those curves.
So that there's going to be, I guess, not much of a change in ventilation at 35.8. You can see that there's for a majority of those partial pressures of oxygen, there's not a huge change in ventilation until you reach that below 60 millimeters of mercury. However, as the PCO2 increases from up to 43, then up to 48, you can see that at a higher level of partial pressure of oxygen, the minute ventilation is going to increase earlier because of the higher partial pressure of carbon dioxide.
Yeah, that's right. So just to give another take on it, but everything you said is right. So this is a graph of alveolar PO2 and the changes in minute ventilation that changes in alveolar PO2. Yeah. What it shows is three different graphs of differing and rising PCO2. What you can see is at 35.8 alveolar PCO2, you have the normal graph where you have a increase and rise at below 60, below 50 millimeters mercury. Yeah. If you were to increase the CO2 marginally to 43, you'd see an increase even after about 120 PO2. So there's an increase in the gain of the system, and that increase is even more dramatic as you increase the PO2. So there's a synergistic effect.
Yeah. Okay. Cool. Thank you.
All good. Guys, any questions about any of that we've covered so far?
Can I ask one question just about the Pao2 chemoreceptors?
Yeah, absolutely.
So it's just in relation to, so these sense oxygen tension rather than oxygen content.
Yes,
correct?
that's right.
And some people might be familiar. There's a question that it's been asked a couple of times in the exams about like isovolumetric hemodilution of the blood and what effects that has, which is effectively a reduction in hematocrit, which, and the examiner's report of one of them went on about basically like increasing sympathetic drive and cardiac output, and seemed to suggest that it was as a consequence of being sensed by peripheral receptors as opposed to a reduction in blood viscosity. But I just wanted to ask a question that if you reduce your hematocrit or your oxygen carrying capacity by way of reducing your hemoglobin, that shouldn't affect your oxygen tension, right?
No.
And how is that sensed?
Yeah, good. So, so the first thing to say is that none of us, and not even the examiners, are physiologists of any capacity, really. So I'm gonna, what I'll say is true statements, and then I'll find out exactly. So in this particular question, I might actually get you to, if you've got that handy, to email me the examiner's report and the question itself, and I'll be able to give a comprehensive answer. I can do that today or even by next week. So first of all, West's quotes, PaO2 and not O2 content is what triggers these peripheral chemoreceptors. Therefore, they're not stimulated simply due to anemia or something like methemoglobin. So that's the first true statement that you'd have to take from West, the prescribed reading. So then the question is, how does a decrease in hemoglobin affect? So is your question then, how does a decrease in hemoglobin, say anemia or blood loss of some sort, how does that affect respiratory rate? Is that right?
Yes, and then also how does that link in with sympathetic drive to increase cardiac output?
Okay, good. So I think the cardiac output question is more of a cardiac topic, but easy enough to answer. Why don't you, are you able to send me that full question, and I'll get back to you about that?
Yeah, not a problem. Do you want me to send it to you now or after the treat?
Actually, send it to me now. Just
and Andrew, can I ask a question? And this could be totally wrong, but is it more related to the flow and effects of reduced hemoglobin causing reduced oxygen delivery, causing increased CO2 from like your respiration, and then your increased CO2 causing increase in minute ventilation?
Well, yeah, that's why, because how I answered it, and this was a little bit different to what the examiner's report alluded to, was basically reduction in hemoglobin, reduced blood hematocrit, reduced viscosity, and that has, you can talk about resistance, and that increases preload cardiac output. And then if you dump it low enough, you get cerebral acidosis, and then that is sensed by central chemoreceptors. But I'll just send the question through, but I don't want to waste too much time if you're planning on moving on.
I think it's a really good question. I'll see the context of the question and everything, but it sounds like you've got a pretty reasonable answer there.
So yeah, I've just got to open up MAC 95 and find it, but it was in the 2013 A exam, and then it was asked again, I think in 2019, with a slightly different way of asking it, but it was effectively asking the same question, saying, if you gave 2 liters of Hartmann's to someone, what would happen?
Yeah, good. Yeah, I'll have a look at it. We'll probably have a break around 9:30 or so. So yeah.
Okay, cool. I'll find it while you continue on. I'll find it and I'll email it to you in the next sort of couple of minutes.
Yes,
Andrew, I'm just quickly looking at it just to quickly tell you one thing. It's just saying that in their answer, they said activation of the sympathetic nervous system at critical levels of anemia. So I guess then that would kind of fit into what Imogen was saying. So maybe it's only at like critical levels of a lower hematocrit, not just isovolemic hemodilution. But anyway, we can talk about it later.
Yeah, because I think if you dump your blood pressure low enough, you'll get the effects of hyperperfusion of the carotid sensors, and then that will read it as well. But yeah,
good.
Anyway, I'll send it through, and I just got to. Have you got it up, Alex? Do you want to just quickly email it through?
Yeah, I can do.
Yeah, thanks, Alex. Cheers. Okay, so the next part of the syllabus is describing the properties of surfactant and relating these to its role in influencing respiratory mechanics. So I want you guys to just speak out loud and just to again be able to explain this. Surfactant is definitely one of those topics that can be reasonably tricky in explaining it. So Imogen, do you want to tell me about surfactant?
Yep. So I got that it was produced by type 2 pneumocytes. It reduces the surface tension, thereby increasing compliance. And I suppose if you want to elaborate that further, you could probably write Laplace's law down. Basically, by improving compliance, you can minimize your work of breathing.
Fantastic. And so that's okay. Does it have any other functions besides that? Increased compliance, reduce work of breathing.
I feel like there's an immune function related to it, like trapping of foreign substances and things, but I can't quite remember. That's
right. So keeping out the dry, preventing transition of fluid from capillaries, and then I've just put here inflammatory respiratory distress syndrome results from a lack of surfactant as well. Can you explain to me what's happening in that diagram, alveolar 1, alveolus 2?
Yes, I can try. So I think this diagram is essentially illustrating Laplace's law, which is that pressure is equal to 2 times the surface tension over the radius. So in alveolus 1, you've got reduced radius. So there's increased pressure. In alveolus 2, there's an increase in the radius.
Great. And so is this a, oh, sorry, keep going.
So increase in radius and reduced pressure. Oh, hang on. Now I've just seen the arrows. So this is talking about the redistribution. I mean, I think this is kind of getting towards slow and fast alveoli, but
so first of all, is this a normal state or an abnormal state, this diagram?
This is a normal state to protect this. Go on.
I'm going to say it's an abnormal state because it's saying that P1 is greater than P2, and we don't really want that in the lungs.
Yeah, you're right.
Yeah. So considering that this is an abnormal state, what's going to happen in this diagram?
So airflow is going to flow from alveolus 1 into alveolus 2, causing further increase in the radius.
In the radius of? Of
alveolus 2.
Yeah, absolutely. And that would be just, a ridiculous situation, because if you imagine the lung with so many different lung units and alveoli, it would be, essentially, you can imagine a state where there's so many different sizes of alveoli that eventually, all the small alveoli will empty into a few larger alveoli, and that would be just completely ridiculous. So how does surfactant then work? How do you make sense of that?
So surfactant then stabilizes the alveoli.
Yeah, good. I mean, keep going.
No, I'm just trying to think about this diagram.
Actually, let's go to the
probably throwing me off.
This is the best diagram I've seen so far. Maybe it isn't.
No. So my understanding of surfactant is that it creates that lateral wall tension, which you can see from the arrows when it's talking about the surfactant molecules, which then holds the alveoli, like it's trying to prevent that alveolus from collapsing inward on itself.
And so the way I guess I try to understand this then is that it's pretty much that in abnormal, in a situation of varying sized, spherical structures like this, you will get, you'll get the emptying of the small spherical structures, the small alveoli into the large alveoli. So surface tension there, therefore, has to provide a force that prevents that from occurring. And then you can imagine in this graph that if you have, if you have these pulmonary surfactant molecules very close together, that will then stop it'll stop the forces that are causing that to collapse, the attractive forces that are causing it to collapse, according to Laplace's law. So it's directly acting against what would be the tendency according to Laplace's law. And so if I was to draw this as a diagram, I'd essentially just draw something like this to show that the closer the molecules are together, the more repulsive forces they have to then allow the alveolus to stay patent.
Mm-hmm. Yep, makes sense.
Yeah. Let's move on to this topic now. So I'm going to get you guys to, again, take a couple of minutes. I want you to answer all of these questions out loud. And then then I'll ask someone. So Andrew, I might pick on you for this one. You're next, if that's all right. What is compliance?
Is that how many Andrews are there? Is that me?
Oh, Andrew Talman?
Yeah, that's me.
Yep.
Okay.
Sorry about that. I think of everyone just having a Lahiru name.
So my understanding of compliance is it's effectively a measure of distensibility. So how easily something's volume increases for a given amount of pressure. So mathematically, I suppose it's change in volume divided by change in pressure.
That's perfect. So I like that you use the term distensibility. I think that's probably the simplest layperson's term to describe it. How about elastance?
It's effectively the inverse of compliance. So where compliance is change in volume and pressure, elastance would be change in pressure on volume.
And what's your layperson's term? If distensibility is to compliance, what is to elastance?
I kind of think of elastance like the recoil of something. So where something's how easy it expands, elastance is how strongly it resists expansion or pushes back in.
Okay. I like the term resisting expansion. So the word I've got here is stiffness. It doesn't necessarily recoil inactively. Yeah, I'm wrong about that. That's right. And you mentioned correctly, volume change per unit pressure. And we've got a graph on the side there. What is the formula, Andrew, for total compliance?
So total compliance is, I suppose, a combination of the compliance of the parenchyma plus the chest wall, and they kind of oppose each other. So the formula I've remembered is 1 over each. So 1 over total lung is 1 over lung plus 1 over chest wall.
Yeah, sounds good. And what's the normal value, supine and upright?
For total lung or for each? Well, each individual is 1 over 200. So together that equals 1 over 100 mils per centimeters of water, I think it is.
Yeah, sounds good. How do you measure it?
I suppose it depends on whether we're measuring static or dynamic.
Yep, let's go to static to start with.
Sorry?
Yeah, let's go to static to start with.
So static is, as it sounds, static with no airflow. So there's no resistance to flow. So if you'd have to, I think you just have to basically graph it, but pausing airflow and measuring the volume for any given pressure. And then you graph it like the graph you've kind of got there.
Yeah, good. How do you measure the intrapleural pressure? We had one examiner when I was studying, and he used to ask a lot of, throughout these topics, so I'll be asking, how do you actually get the values on something? And so this particular examiner was really big on asking this. So I assume that it will be reasonably the same anyway. So yeah, how could you measure this intrapleural pressure in real world studies?
I mean, I suppose you could put a pressure transducer in there but that would be quite invasive. So as a surrogate.
Yeah, so they actually use a transesophageal manometer. You have to put the patient's upright, it's in the lower third of the esophagus, and you can measure volumes and pressures then as you do that. But like exactly what you said, you graph it. When you graph those results, then you get your curve. Do you have your glottis open or closed when you're measuring these pressures and values?
Well, they have to be open because the pressure inside needs to be the same pressure as outside with no flow. So if you've closed your glottis, they wouldn't equivalate, if that makes sense.
Yeah, that does. Yeah. So closed. So it's open glottis, holding the volume steady. What is hysteresis?
I always find this really hard to define, but I think it's basically describes a phenomenon where the measured value differs depending on whether you're going up or down. So for any given pressure, if you were to stop it at that, I think that would be a really perfect and simple definition, just to give you insight into that. So what you said there, I think, yeah, and I agree. I think a lot of us had trouble explaining this from the very start. But if you would just say what you said again, I think that's a really good way of just keeping it really simple and then moving on from this. You want me to say it again? Or?
Yeah, just say it again for everyone.
Well, I think I said something along the lines of for a measured value of something changes depending on whether you're going up or down. But I'd actually say breathing in or out because we're talking about breathing.
Yeah, absolutely. And can you think of any other examples of hysteresis?
There's probably lots.
Yeah. There's something about the lungs, a property of the lungs that makes other systems like that exhibit hysteresis.
I imagine anything that has like compliance and elastance, like, your LV compliance and stuff probably has, when you expand your LV during diastole versus contract it in systole, probably has an element of hysteresis, although I've never graphed it or looked at it, but I imagine
it may have, because they deal in such smaller volumes, it's probably far less significant. I haven't seen that as a fact, so I would like that. But anything elastic, an elastic band exhibits hysteresis. That's probably the easiest kind of real world example of that. So moving on, what is dynamic compliance?
So dynamic compliance, well, I suppose includes. Well, it's the opposite of static, I suppose. Where static is with no gas movement. Dynamic compliance is the compliance while breathing, and that will always be less compliant than the static. And the reason for that is because you add in airway resistance and elastic forces.
Yeah, that is right. So how do you then measure dynamic compliance?
Presumably just by graphing someone breathing, like on a pressure volume graph, but I don't know. Like, when you're on the ventilator, you can flick up the flow volume graphs and stuff. I suppose that hysteresis is dynamic compliance because they're breathing.
Absolutely, that is correct. So in just for everyone's information, in nuns, I'm pretty sure they have like a curve, like a flow volume loop like that. Can everyone see? Andrew, can you see the diagram that the stuff I'm annotating on that?
Yeah.
Right?
Yeah.
So I think they've just got this circle, which doesn't really say too much. Essentially you have a point of no flow here, and if you join that up, you can get you can figure out the angle of that, finding out what the dynamic compliance is. So when I've spoken to people in the respiratory lab, essentially you get increasing pressure volume loops, and you join up the points of no flow, and those points, sorry for the bad graph, but that angle there is your dynamic compliance. And so that's pretty much it. Just to give you a bit of background for how dynamic compliance is measured, if that ever comes up in the Viva, that's what that diagram from nuns really means.
Lahiru, can I just ask a quick question on that? Because you've said that they're taking the points of no flow, but yes. Dynamic compliance is
that's really good.
not
Really good.
static?
So if you imagine, so if you're measuring static compliance, you take a deep breath in and you hold that, and that's point of no flow. That makes a lot of sense. How can I possibly have dynamic compliance in the point of no flow? It's pretty much by the very small moment where I stop inspiring and then start to expire. That's a point of no flow. It's only for a moment in time.
Yeah. Okay.
That's how they measure that point of no flow and call it no flow. So it's actually not no flow. It's just a pause and flow.
It's a transition.
It's a transition from inspiration to expiration.
Yeah. So does that mean that you can't really talk about, when they talk about dynamic compliance, they're talking about that transition point rather than like the compliance during inspiration and the compliance during expiration?
As in, I didn't get your question, Imogen. Sorry, say it again.
Sorry, I just get very confused with compliance when they ask questions about it, and I sort of muddle myself up, kind of like I'm doing now. So, is dynamic compliance? Can you talk about dynamic compliance at any point along the hysteresis, or is it only at that transition point?
I would not think about hysteresis as the first thing. All I'd say is that your dynamic compliance is measured during regular breathing, and that you're not pausing your breath at all. So far that makes sense, right?
Yep.
Once you get increasing volumes, you measure the points where you're changing from inspiration to expiration, and those points will then line up to give you an angle, give you a measure of compliance of volume pressure.
Yeah.
I think that's what I would say.
Sorry, I think I've just clicked. It's all right. I've just clicked.
Excellent. You're good.
Thank you.
No problem at all. Which is greater, static compliance or dynamic compliance, Andrew?
So static compliance will always be greater than dynamic because you're removing the element of airway resistance.
Exactly. How does dynamic compliance change with respiratory rate?
I mean, most of the time it will get worse, but I suppose it depends on the lung mechanics, kind of like work of breathing does. So for someone who has a restrictive lung deficit, obviously, they're going to find it easier to, like in asthma, the work of breathing is reduced with reducing respiratory rate and increasing your tidal volumes. Whereas someone with a restrictive deficit will have a reduced work of breathing by having small tidal volumes and a high respiratory rate.
I'm just going to take away the work of breathing from this for a second. So I feel like the only difference here that really matters is the fact that if I use static compliance, I give time to equilibrate to all the slow alveoli, and the faster my respiratory rate is, the less time I have for these slow alveoli to fill up with gas. So forgetting work of breathing, if I breathe, at 6 liters a minute, I will have some slow alveoli not fill. If I breathe at 3 liters per minute, I'll have far more slow alveoli not completely filling. And so, at any given rate, if my rate is faster, I'll just have less lung tissue, getting my tidal volume into it. Therefore my compliance will decrease. Does that make sense? Like I feel like I don't need to worry about work of breathing to explain that.
Yeah, I just thought because because compliance, we're talking about total compliance here. So it's okay.
No, that's so good. And then just quickly, what's specific compliance? Just for complete.
So it's just a way of, I suppose, normalizing compliance to lung volume, because although it shouldn't change with age, it will change with volume. So it's just the compliance divided by a volume. Generally it's FRC, but you could probably use any volume. But FRC seems to be used by convention.
Yeah, sounds good. That way you have a unit that takes away the absolute total volume. So yeah, that's good. What are the factors that affect compliance? Kristen, do you want to have a go at this one?
Sure. Hello. I thought if this was sort of SAQ'd, start off with the definition of compliance and maybe break it up into the chest wall factors and lung tissue factors.
Yes.
And then from there, you could even break it down further into patient factors and then say drugs or other factors. So in patient factors, and I didn't think of the chest wall versus chest tissue until halfway through, but disease states, so such as pneumonia, APO, fibrotic lungs, are obviously going to decrease compliance. In newborns, if they lack surfactant from premature delivery, again, decreasing. Patient positioning, supine versus standing. Perhaps you could add in surgical procedures there, pneumoperitoneum, airway, and then other sort of parenchymal factors such as things we've already mentioned, airway resistance, our work of breathing or our respiratory rate, our total lung volume in male versus female versus children. And then other chest wall factors would include burns or trauma, preventing chest wall expansion, and then drugs, muscle relaxation, and either GA versus spinal anesthesia.
Excellent. I didn't even think about the drug factors. That's really great to have that included. And just imagine, like, broadly speaking, we have lung factors, volume stuff, elastic stuff, surfactant, chest wall, like you mentioned. I think of normal and abnormal as well in that situation. And then I've just chucked in here dynamic compliance factors. I forget whether you did that as well. But, in any of these exam questions, I think we've all seen that examiners will on one page say, you should have done this, and another page say, disappointing to see candidates, going onto this tangent or whatever it is. But I think this is about having a really good structure so that you're passing your mark based on, based on a good structure that doesn't depend on the individual assumptions and biases of the examiner. So I like the fact that, you had a good structure and you mentioned pathological states and drugs as well, because you never know what a particular examiner might think is important, and they're just humans who have their own biases. So I think that's a really good way of trying to get as much into it as possible. So yeah, well done.
Thanks.
Annie, can you tell me what a time constant is?
A time constant, I think describes usually a rate of a reaction. I think about it in the inflation wise, it's the time taken to reach about 63% of the final volume of the alveolus.
Yep. Any other definitions before we move on?
I think
there's a particular, for the very bottom curve, y equals e to the negative kx.
Yeah.
The most common definition I've seen for an exponential process, how long it would take for an exponential process to complete.
To finish, given at continuous at the current rate, I think.
Yes, correct. The initial rate of change had not changed. Initial rate had not changed. Great. So drawing the curves, which is obviously up there. And yeah, can you how would you describe it for lung inflation? No, that's fine. We've gone through that. Give me a real world example of each of those three curves that you see on the screen.
I'm trying to see the real world example, as in anesthetic or non-anesthetic?
Oh, whatever you want, really.
So the first one could be the number of bacteria you see in a blood culture. Exponential growth.
In Italy?
Yeah, that's right.
Too soon. Next one, go for it.
And the second one is reaches some kind of asymptotic maximum. So real world example to that. So
this is very anesthetic related. What do you reckon?
I am drawing a blank.
That's right. How about the last one?
Exponential decay. So that could theoretically be, in a way, drug clearance.
Yeah, absolutely. So normal, first order kinetic can be the bottom one. Washout, nitrogen washout, or volatile washout. The middle one could be wash in, of any agent?
I am.
Yeah, and that's often the thing that we bias ourselves to talk about in this context. And then hopefully everyone's got the figures. So 1 time constant 63, 2 is 86.5, 3 times constant 95, and 99% for 4 time constants. Okay, so this is a bit of a question for you guys to think about. I want you guys to imagine, so fast and slow alveoli. So imagine alveolus A and B. The time constants of A to B are 1 to 2. So B is obviously a slower alveolus. Which alveolus will achieve a larger volume? So it just takes 10 seconds now. I want you to tell me which alveolus will achieve a larger volume.
Is it B?
Yeah, so the answer is actually that. Actually, so when I was reading nuns about this topic, I just thought this would be one of those things that would really test your understanding of what a time constant is, and potentially a really good little Viva question that could occur. What is the ultimate determinant of the volume of each of these alveoli?
Resistance and compliance.
Yeah, and that's the resistance and compliance is the time constant. But when you think about it, if you had all the time in the world, what would be the ultimate determinant for that alveolus, of the volume for that alveolus?
Compliance?
It'd be time, right?
Exactly. It'll be
time and radius, yeah.
But if you get it ultimately the whole time to equilibrate, it wouldn't matter what the resistance is, because eventually you'd get like equal.
Exactly. So essentially, when you get a couple of alveoli with varying time constants, the one that will be largest is the one with the greatest compliance. So a bit of a trick question. If you get fast and slow alveoli, the answer is the time constants are irrelevant to the ultimate size of the alveoli, as long as you have all the time in the world. That was pretty much the point of that. That's good. Andrew Tan. Andrew, what do you reckon? What's the intrapleural pressure at FRC?
Sorry, I've seen this graph before. I'm just trying to remember.
Yeah, no, it's all good.
Intrapleural pressure FRC is about 25.
So relative to atmospheric pressure, the intrapleural pressure, is it going to be a positive or a negative number, first of all? If you imagine that space in between the chest wall and the lung, with both recoiling in the direction, in opposite directions, what do you reckon?
So one's a negative and one's a positive. I think the relative difference is 5, wasn't it?
Yeah, -5.
-5, yeah.
And the way I imagine that really is, I've got actually, I'll ask this question. So your chest wall at FRC, where is that trying to go? Where is that?
It's a balance between expanding from the chest wall. Oh, sorry, the chest wall, yeah?
Exactly, expanding, right? So it's trying to recoil outwards. So it's stuck in this state, which is, but it's trying to recoil, outside. How about the lung?
The lung is trying to collapse from the elastic properties.
Yeah, exactly. So that makes sense then, that the intrapleural pressure in between them is going to be a negative pressure. Good. That's the first truth out there. What happens to the intrapleural pressure with a pneumothorax, Andrew? What do you reckon?
Well, the intrapleural pressure will be positive now instead of negative because of air in the intrapleural space, and they've lost that relative difference between the intrapleural cavity and the alveoli in the lung.
Beautiful. So I want you to give me a value now, because I'm not sure I got your answer. If I put a hole in the chest wall of the lung and it rushes in, what is that pressure now?
It'll be atmospheric pressure.
Exactly. So give me a number relative to atmospheric pressure, which is probably really obvious, and it is exactly what you say. If previously it was -5, what is the number now?
Relative to atmospheric pressure, 0.
Exactly. Perfect. So we then move on. Which way does the lung want to recoil? Inwards, chest wall outwards?
chest wall. Yep.
Perfect. Draw a graph of airway pressure versus lung volume. So, you know, this is not something correct me if I'm wrong. I've never seen this graph being asked to, asked to be reproduced in a Viva, or, and no one's told me that it has, but if it has, please let me know. Because it's obviously a pretty busy graph. Andrew, now, I want you to describe for me this graph, and, it's obviously a pretty busy graph. I want you to just tell me true statements and then tell me interesting points that this graph might be trying to communicate to us.
Okay. Let's see.
And I think we can all acknowledge that this would be a really annoying graph to get.
It is an annoying graph. I actually remember watching the video on this from Wes. So there are three separate lines here. One's from the chest wall compliance, and there's the lung compliance, and then there's a combined compliance. The graph is actually very interesting because in terms of airway pressure, you got the middle line being 0, then it goes negative on the left and go positive on the right. Then it's measured relative to vital capacity as well as the total lung capacity on the right. So here's a picture of someone taking breaths or expiring. It's a spirometer that's measuring the volumes and the airway pressure. So as you inhale, I'm looking at the lung initially.
And so good system. Follow one line first, explain that, follow the next one. So keep going, that's great.
So as we're inspiring, and there is now a positive difference between our pressure in the mouth and the lungs, and air flows in, the airway pressure actually goes up as the lung reaches 100% of vital capacity. And then looking at the chest wall is actually very different because you can see that it didn't start from 0, it starts from -20 and or -25 here with when vital capacity is 0. So as we are inspiring, the negative territory becomes less. Why is that?
And always good to ask a rhetorical question in the exam.
Sorry, I'm drawing a blank here. I'm just trying to remember this graph.
No, that's right. So if you were to, I mean, I think you're doing well. So if you were to just describe what happens, imagine the chest wall. The chest wall is, really small, right? Like the volume from the chest wall is small at 0% vital capacity. So that's -20. And as you inspire, it's still negative, still negative, still negative. And then at a certain point, it gets to 0. What is that point? So that to me, that's what's interesting about the chest wall line. Whenever it crosses an axis or a particular line, that to me is worth communicating.
So where chest wall pressure becomes 0.
Yeah, and how does that relate then? So at what volume or percent vital capacity does the chest wall get to 0?
And when it's almost 80% of vital capacity.
Perfect. So imagine this, right? So you've told me that the chest wall always wants to recoil outwards. Then to me, what's interesting about this is that at 75% of vital capacity, suddenly it wants to recoil inwards. That, to me, that's interesting, yeah?
Right, because it has expanded almost fully and it's trying to recoil.
The natural state of the fibers, the tissue, the ribs, whatever it is, everything in the chest wall wants to recoil outwards, but then it only exists like that up to a certain point, and then after 75% of vital capacity, so imagine taking the largest breath in that you can, up to 100% vital capacity, now your chest wall wants to recoil inwards, like, which is unusual for the chest wall.
Yeah.
Yeah. So then I think about, what are the other interesting points? So really, I can describe the chest wall line and how at 75% of vital capacity, it does something different. It starts recoiling inwards instead of outwards. How about another point? Like, the lung and chest wall, there's a point that it intersects the axis there. that's probably worth describing as well.
Yeah, there will be FRC where the balance between lung wanting to expand outward and the chest wall wanting to expand outward and lung trying to recoil inward is at an equilibrium, and that's where we have FRC.
So that's right. So I think so. What you did really well there, you described what we're looking at. We're looking at a graph of lung, chest wall, and the combination. These are true facts on a very busy and complicated graph. But you simplified it, and you then said we're measuring airway pressure, and we're measuring the lung volumes as a percentage of vital capacity or total lung capacity. Again, easy to state. All you have to do is have eyes and be able to read words to get that. But still, you're ahead of most people by saying that, because this is a very panicky-inducing, graph. And then you can describe each of these lines and say, look, I think the most important things are, firstly, the chest wall line has a recoil outwards, and then at 75% of vital capacity, recoils inwards. The lung is interesting; it goes down at minimum volume to a 0% pressure, but as the patient inspires, that increases in a linear fashion. Interestingly, at FRC, you have equal inward and outward or recoil pressures of the lung and chest wall in opposite directions. I mean, if that's all you said, I think that's a pretty good demonstration of what this graph is saying. Alex, do you want to have a go at this? How does the intrapleural pressure change from apex to base of lung?
Sure. So my understanding is that as you go from top to bottom, the intrapleural pressure becomes more positive. And that's because of, I think it's because of the compressive forces of gravity. So the sense that the weight of the lung is compressing the lower part of the lungs compared to the top where it's more aerated.
Perfect.
In terms of which part of the lung is easier to inflate, my understanding is that the lower part of the lung is at the lower part of the compliance curve. So it's got a greater ability to be distended. So therefore you'd have better inflation at the lower portions of the lung.
Sounds good.
And which part has greater ventilation well, I guess you have less mismatching at the lower part of the lung as well. As far as I was aware, like the top of the lung is almost completely expanded because obviously due to gravity, they're all aerated. So you can't expand the alveoli any further. So it's at the higher portion of the compliance curve. So yeah, the lower part would have greater ventilation, I think.
So just for anyone who's probably started doing this in it, yeah. So when you look at alveoli at the top, they look larger. At the bottom, at the base of the lung, in an upright lung, they look smaller. But because they're on a better part on the compliance curve, then they have their ability to inflate is greater, and so therefore their ventilation is greater. So pictorially, it looks a bit odd. In the larger lung, the larger alveoli at the top seem like they might be easier to ventilate, but really it's whichever alveoli are on the better part of the compliance curve.
Yeah.
So so then moving on, what happens at low lung volumes?
So again, relating it to the curve, then you're moving further to the left of the curve that we're looking at. So your compliance is probably low in the sense that like it is at the top of the curve. It has to work harder to open up those alveoli based on, actually maybe I'm getting confused with surface tension now, but my thought was that you'd have, at lower lung volumes, you'd have more amounts of alveoli that are collapsed.
Yeah, that's correct. I've just drawn two pretty bad arrows. So any low lung volume state, examples are general anesthesia. And then suddenly the apex of the lung moves down to this really great ventilating or really very compliant portion. And the base of the lung moves to the less compliant portion. So yep, what happens is you'll have at low lung volumes, the apex is better ventilated.
Okay, yep, okay.
So airway closure only occurs at very low lung volumes in young, healthy people. Why is it that elderly people have airway closure? What do you reckon?
Is that because of the closing capacity becoming greater than your FRC? So, up until I think the age of 40, your FRC is greater than the volume at which airway alveoli collapse. But as you get older, that closing capacity becomes greater until it overcomes your FRC, which means you have a greater likelihood that your alveoli will collapse.
I've got here the aging lung loses elastic recoil, so the intraplural pressure are less negative. So it's the situation at lung volume. So I'm not going to invoke closing capacity, because that's just going to add extra level of discussion that we don't need to discuss now. Aging lung loses elastic recoil, therefore intrapleural pressures are less negative. If they're less negative, that looks like a low lung volume lung.
Okay.
Alveolus.
Does that just mean that they've got lower compliance as well? Is that what they're saying? Like,
if they have less elastic recoil, they'll have less compliance.
Yeah.
Describe closing capacity and its relationship to airway closure, and explain its significance and measurement. Dominic, what do you reckon? What is closing capacity?
Sorry, I haven't done this one for a while.
No, that's right.
But closing capacity, as far as I can remember, is the maximal volume at which dependent parts of the lung airways begin to close.
Yeah, so I've just kept it probably a bit simpler with a few less words to lung volume below which there's airway closure. You know, regardless of depend or not, but maybe that would be an effect in it. Keep going.
So in terms of what is a capacity versus a volume?
Actually, before that, what is the closing volume made up of? Or closing capacity made up of?
It's made up of the closing volume plus the residual volume.
Perfect.
Yeah.
What's the capacity versus the volume?
Well, I guess I'm not too sure about this one, actually. I hadn't considered it before. But I guess it's a capacity is more... Nah, I have no idea, to be honest.
No, that's right. So when we look at the spirometry and lung volumes, you notice that the capacity is made up of more than one volume. As it will just be a technical term. You can't reduce a volume by definition.
Okay.
Beautiful. Does closing capacity depend on body position? And you got a clue with the graph to the left there.
Yeah, it does depend on body position.
So no, it doesn't.
No?
Yeah, so regardless of the patient being up, so the FRC does depend on being upright or supine, but the closing capacity simply just... Actually, do you want to just describe that graph for me? Again, just say true statements.
Yep. So on the y-axis, you've got lung volume, and on the x-axis, you've got the age in years. So this graph has a line describing closing capacity over a variety of age groups. And as age increases, lung volume increases. There are two intersecting...
as age increases, what increases?
Lung volume.
So
the closing capacity volume increases. Is that what it's like?
Yeah, and I think you got the right angle, the right you know, the gist of this. But all you have to say is as your age increases, the closing capacity increases.
Okay.
And that in itself, the closing capacity is defined by liters, which is a volume measurement, but you don't have to say the closing capacity volume necessarily, just say closing capacity increases. Good. What else have I got here? Great, so...
I guess my question is, why the intersecting lines for are those just showing you what your lung volume would be at FRC supine and FRC upright?
Yeah, and when you think about it, like the practical application of this is like, let's say, you know, 36, 37 years of age. If you are supine, your FRC will then, you know, equal closing capacity or potentially be greater than closing capacity at ages above, you know, your late 30s.
Yep.
So what does that mean? What's significant about that? Think of what a closing capacity does. If your small airways start to close, how does that affect you physiologically?
Well, if they start to close at larger volumes, you would be decreasing your... Well, just like a broad kind of way of thinking of it, you'd be decreasing your ability to ventilate because you're closing them off, so they're not participating in gas exchange.
Yeah, so I'm going to take away that term ventilate and say that that's not going to be as bigger issue.
Yep.
And we'll get to that when we're talking about shunt. But you know, imagine now you've got some closed alveoli and blood is flowing through past those closed alveoli. What's that going to do?
Well, you're increasing your dead space.
No, it will be shunt. That's right.
Shunt.
Don't worry, we'll get
I
to all
thought
that.
you said shunt. I was like,
yeah.
sorry, I'm overthinking this.
The beautiful part about this is that this is the best way to learn to be, you know, examine, you know, be asked by myself or someone on this, and you'll probably not, you know, forget it because you put on the spot, which is good. So the way I think about it, you know, once you get into your late 30s and above, then when I'm supine, I will have some shunt just based on the fact that my lungs have started closing, which is kind of crap, really. And then at the age of what is this, around, you know, your late 50s or your mid 50s, the same thing happens even when you're upright, and you know, to a greater degree when you're supine. And that will be a really important thing for my oxygenation. If I have greater amounts of shunt, then I will have less oxygenation than I could possibly have if I didn't have that closure. Yeah, so that's pretty much it, really.
Great, thanks.
No worries. So what cause of hypoxemia does closing capacity cause? So that's shunt.
I just had a quick question about that. For the clinical significance part, is the shunt the only thing that's specifically clinically significant about closing capacity? Like, obviously you're moving to a less compliant part of the curve, but is that more just a function of volume and not specifically of closing capacity? So should we only talk about shunt?
I've only seen this impact based on the fact that it's shunt, but could you ask that question again? So, or you can tell me, how else could we apply this clinically, or, you know, or in the real world? What do you reckon?
I suppose the other things I thought of was gas trapping and the decreased compliance, but I suppose the decreased compliance is more just a result of reducing lung volume, right? Not necessarily specific to closing capacity.
Exactly. So maybe, you know, you could think of compliance having many factors, and maybe if it's, you know, a significant amount of lung volume is not participating or is lost, maybe that could. But then I'm extrapolating stuff. Was anything else there? Because I definitely want to hear those other things, because, you know, maybe there's an examiner's question that I haven't seen that does go into closing capacity. I'm really happy to you know, for you to share that as well.
No, it's not. It hasn't come from anywhere. It's just.
I
was just wondering if there was any other clinically significant attributes for closing capacity, but that sounds fine.
Yeah, cool.
Could you, sorry, I just had a thought in regards to that. Could you relate it to use of your FRC in a supine position for pre-oxygenation?
In terms of, like, you know, pre-oxygenation literally just gets the lungs as filled with oxygen as possible. So yeah, I guess you could say that you wouldn't have oxygen being, I guess saturated or pre-oxygenated into those areas. So you couldn't possibly get as much pre-oxygenation as possible. That's in the stuff I've read about closing capacity over the years, that's never come up as a thing. But, you know, if you're writing an answer and it's a extra note at the end, I can't see that being a wrong statement. Yeah.
This is why PEEP works, right? By having PEEP, you increase your FRC to beyond your closing capacity and therefore utilize that part of the lung, is it?
Mm-hmm.
Yeah, potentially.
Joe, like PEEP will increase FRC, right? So with PEEP, for someone like an old person supine where closing capacity is greater than FRC, and you've got airway closure, by having PEEP, you can increase the FRC to beyond the closing capacity, and then you use that lung.
I think that's a really good point, actually. Yeah.
Yeah.
I mean, these days when I pre-oxygenate, I just chuck on PSV Pro with 5 and 5 of pressure, 5 of PEEP, and, you know, I haven't thought about it in terms of closing capacity, but yeah, you know, in really obese patients, it definitely, you know, you get a really fast pre-oxygenation time and a very long desaturation time.
Sorry, Andrew, can I just get a point? So I would say, would you say it increases your FRC or it maintains your FRC when you're going into supine? What were your thoughts regarding that?
Well, FRC is defined as the volume of gas left in the lung at end of expiration, right? So if you increase your FRC, which is your positive end expiratory pressure, you're going to increase the amount of volume in the lung at end of expiration. That's one way of increasing FRC is to have PEEP. That's why it improves oxygenation, because you
Oh no, what I'm saying is like if you've got like FRC's 3 liters and you're going into supine, that'll decrease your FRC in a sense, but you're really just getting it back to what it, like you're never going to go above 3. Is that the thought?
Well, you go to as high as you have pressure. So yeah, like, you know, you lie flat, you've got worse compliance as a consequence, you've got less FRC because of, you know, changes in abdominal and chest wall compliance and all of the above.
Yeah.
But your closing capacity remains the same. So just say if your FRC supine was, I don't know, 30 ml per kilo and you're old, so your closing capacity is approaching that, and then suddenly you lie supine. So suddenly now your FRC is less than closing capacity. So you've got airway closure and you're not able to utilize that lung. By providing PEEP, you can increase your FRC to beyond closing capacity. And now you're able to ventilate that lung because you're not gas trapping, if that makes sense.
Yeah, I definitely get, maybe it's just semantics, but that's all right. I might just leave it there. That's cool.
Yeah.
I have a slightly different way of thinking about this to Andrew in terms of PEEP with closing capacity, because my definition of closing capacity was the point at which there's reversal of the transmural pressure gradient, which is essentially the point at which lungs collapse. And I think about PEEP as actually like preventing that reversal of the transmural pressure gradient. So I think about PEEP as improving your closing capacity rather than functional residual capacity. And I don't know if that helps kind of explain, like conceptualize that, but I don't know if that's right or wrong.
Is that a thing? Like, is that something that's been studied? Like if you apply PEEP to increase the transmural pressure gradient, does that decrease your closing capacity?
What I'm saying is if you apply PEEP, the pressure in the airways is higher. So therefore, you're not going to get that reversal of the transmural pressure gradient to the same extent, or you're going to need like a larger increase in your intrapleural pressure in order to reverse that pressure gradient.
And,
sorry, Lahiru. Yep.
And you may well be correct about that. And the danger of extrapolating too far is that it's not a studied phenomenon, even though, you know, you could say closing capacity is due to, you know, age and loss of cartilaginous structure and all these other things. And then to apply the next step, because it's not being studied, if the examiner doesn't know about that or it's not something that they want to explore, then it becomes a point of contention. And you don't need that, would be my you know, you may be correct, but you know, you want to give the stuff that's written out there by the physiologists, by West, by nuns, and then any further extrapolation is a lesser important thing in this exam, I think. But you may well be right about that.
So I'm just so are you saying that it's better to think about it in terms of PEEP's effect on functional residual capacity versus the effect on the transmural pressure gradient?
Yeah, only because I've never heard of closing capacity talked about in terms of transmural pressure gradient, but you may be right. Maybe there's something out there in a text or a study that says, you know, closing capacity relates to the transmural pressure gradient, and this is overcome with PEEP, and that affects closing capacity and FRC in a positive way. That may all be true, but because I haven't seen it, you know, imagine you get a question about closing capacity, you'll get your pass mark by defining it, by, you know, doing all the things we've talked about, and then maybe at the very end, if there's something about practical applications, which, you know, we're going into the finesse of this now, maybe you can say this may be a thing. Because I haven't seen it written or studied, it's not something I'm going to put as my own theories. You know what I'm saying? Like there's limited gain in the exam for saying very reasonable things that aren't written down. So even though it sounds really reasonable, it's you just can't necessarily do it unless it's been studied or written. But you can put it at the end as an afterthought, you know, as a side note to say.
Yeah, the extrapolation is definitely my own. The definition came from nuns.
Oh, good. Okay. I'm going to have a look at that. That's good. Excellent. Let's move on to this next question. Lisa, John, what do you reckon?
Hey, yeah, so the three types of flow, so laminar is essentially flow in a straight line as depicted by the diagram. So happens in the smaller airways where it's unbranched, where we don't have as much branching.
Yes.
As you can kind of, you can sort of see from the diagram, but not completely, like flows in like concentric cylinders. So whatever's closest to the wall will be a bit slower than what's in the center.
Yes.
You can describe it by using Poiseuille's equation. So 8 times the length times viscosity divided by pi r squared.
Pi r squared or?
Sorry?
Is it pi r squared or is it something else?
Cubed, sorry, cubed.
Is it cubed or is it something else?
The power of 4, is it?
That's it.
Sorry, I'm saying the wrong terms. So it's, and then, so the second turbulent flow.
I'll stick with you for laminar flow.
Oh, sure.
Being able to get as many points down is really good. So I like the way you said, straight line, concentric circles, fastest flow in the center, flow at the edges is essentially 0. We talk about a velocity profile. Do you know what that means?
No, I don't.
That is?
It's usually slower flow? No, not sure.
Like a parabolic velocity profile.
Okay.
Which relates to the fact that the center is fastest and the edges aren't as fast. So it's a parabolic profile.
Oh, yep.
You mentioned correctly that it's most likely to occur. So laminar flow is most likely to occur in the small airways. Why is that it's in the small airways?
I think it's just because there's less branching, as is my understanding.
You almost said there's more branching, in a sense.
Yeah, probably true, actually. Yeah, no, not sure then.
Yeah, so essentially it's Reynolds number. Reynolds number is low enough that this occurs. What is Reynolds number?
So Reynolds number sort of describes how much, the type of, it determines the type of flow. So it talks about the diameter, the viscosity, the density of the gas, and it, depending on what the number you get, so the higher numbers you get mainly turbulent flow, and if you've got a lower number you get mainly laminar flow. I can't remember the exact.
Yeah, right. So radius times average velocity times density over viscosity, and turbulence is probable with Reynolds number greater than 4,000, less likely less than 2,000, and in between it can be kind of either. So those are important dies. Good. That's, again, I remember the way me and my study mate used to do this. As long as we got lots of facts down, say, you got a question that has 10 marks. We could get imagine each fact is about half a mark. I just try to put as many facts down, and you rightly did a lot of those.
Okay.
One more thing. So the Hagen-Poiseuille equation will just come up so many times, just like fixed law of diffusion. It'll just be the bread and butter equations that you'll just be tested on time and time again. And so something really useful about this equation is then you can talk about each point. What is the most important part of the Poiseuille equation in this context?
I would say the radius.
Great, and why is that?
Because of its power. So its ability to because of its power and because it's the denominator, just its ability to alter the flow is, I guess, greater than the other factors.
And so, and the example I'd then give, so obviously giving, real importance and real weight to the radius will be important in this exam. So, people know that that you get that's a really big part of the resistance to flow. And then, decreasing half the radius is a massive increase due to the, radius to the power 4 effect. Good. Tell me about turbulent flow.
Can I clarify something really quickly?
Yes, please.
Just so you were mentioning how flow is laminar in distal airways, and why that is, and what the important part is in regards to Reynolds number. But it's about velocity of gas flow, right? Because the further you get, you increase your cross-sectional surface area to the point that flow basically goes so low that your Reynolds number is really small. Is that right?
Yeah, look, I'm just gonna, I think you are right, sorry. So if your Reynolds number is very low, then it's likely to be laminar. And so your average velocity is likely to be low. So that's absolutely correct. And what I've got here, just to make sure I'm giving you the right stuff. Yes, that's right. Yeah, so fully developed laminar flow probably only occurs in very small airways where Reynolds number is very low. What did I say? Sorry, did I just say?
That's what you said, but it's about cross-sectional area of the airways, because as you go through the generations, you, I suppose, exponentially increase your cross-sectional area. So resistance is really low, and, yes, and your flow drops right off. And it's
thanks for that. I think that's absolutely right. So
yeah, because just trying to tie it back into that equation. So like, just like how with the Hagen equation, we say radius is the most important. With the Reynolds number, it's about velocity.
Yep, no, I'd agree with that.
Yeah, cool.
Just appreciate that. Turbulence, keep your eyeing Lisa.
So turbulent flow is, I guess, opposite in a lot of ways. It's faster, tends to...
Is it faster?
I thought it was, yeah. But I could be wrong.
Yeah, so look, I've always thought of it as being not as fast. Like you don't have the ordered flow with the average velocity being faster. We keep going with that.
Okay. So as you can sort of see in the diagram, it's less, as you've mentioned, sort of less ordered. You get lots of little eddy currents. It doesn't depend on the viscosity of the gas or what have you. It tends to rely more on the density rather than viscosity. You tend to see it more in larger airways. What else can I say about it? I think that's about all I've got for turbulent flow, actually.
Yeah, that's fine. And look, in NUNS, there's a section that talks about the pressure and how it's related to various factors in turbulent flow. So pressure is proportional to kV squared. Pressure is proportional to density and independent of viscosity. And pressure is 1 over, is proportional to the inverse of the radius to the power 5. Mm-hmm. And so if you take these statements, I mean, these are just true statements from NUNS, but you can see the impact of radius is pretty decent. The impact of density occurs. And also that for any given pressure, the velocity of gas is potentially going to be more affected.
Okay. Yeah.
So what happens in the bronchial tree? How is this different to the above theories? So yeah, tell me about the bronchial tree. Like what is it like in real life?
So I guess you've got a straight tube, and then you've got branching. So my understanding was you get transitional flow. So I guess the simplest way, like I think about it, is a combination of laminar, and then you get a change at a point to turbulent flow, and then laminar flow might resume again. Yeah. Yeah,
good. Yeah, so I've just said transitional flow is a mixture of laminar and turbulent flow with turbulence in the center of the pipe and laminar flow near the edges. In bronchial tree, there's many branches, changes in caliber, irregular wall. So there's lots of factors that make it very much not like a pipe or like a smooth, pipe that adheres to any mathematical formulas. So rapidly branching systems often, like the lung, have turbulent flow, or transitional flow in general. Good. So from these questions then, so can you have ventilation of alveoli if the tidal volume is less than the anatomical dead space?
So I don't think so, but then I kind of second guessed myself, and I was like, is there something I'm not thinking about in this question? Because if you, alveolar ventilation is, tidal volume minus dead space times respiratory rate, then Yeah. Anyway.
Yes, I've got here the fact that you may have some level of laminar flow means that there's different velocity profiles. So if you have some laminar flow at some stage, you can have different different velocities, therefore different volumes received. So it's not just like a chunk of air going into your dead space and out again in respiration. It's you're going to have varying amounts of flow in that segment of your dead space, which means that there'll be some level of gas exchange.
Okay.
What type of flow is better for purging an airway of gas?
I would have thought laminar flow would have been.
Also,
sorry, no, turbulent.
Yeah, turbulent. Yeah, because you have a flat velocity profile, so you get bulk expulsion of gas far better than with laminar flow. In laminar flow, what's the velocity of the gas adjacent to the wall? And I think we've said it's stationary. And will helium improve laminar flow?
So helium, I guess, is less dense, so no.
Yeah.
Because that doesn't come into play with laminar flow, just in turbulent flow.
Yeah, good.
I thought it does. Sorry, Lahiru.
No, that's right. I mean, according to Hagen-Purcell equation, density doesn't play a factor in that. Viscosity does. But what are you thinking?
You could argue that it would reduce your Reynolds number and make the flow more likely to be laminar. So
yeah, that's right. You could argue that. I remember saying the same thing back in the exam. So absolutely true statement. If density may affect it if it decreases Reynolds number, and therefore makes flow more laminar, makes flow more likely to be laminar.
Cool.
And sorry, about this tidal volume being less than anatomical dead space. I'm just trying to picture in my head this air that's sort of stuck in the dead space, not actually moving as much. So you do have gas that's coming in, its tidal volume, but it's less than. I mean, there is a mixture of gas that's going into the alveoli from that perspective, isn't it?
Sorry, Andrew, I didn't quite get that. So.
I was just stuck thinking of air like liquid. You got some dead space volume, then you've got an amount of tidal volume that's coming in, and I'm just trying to imagine if that tidal volume actually gets into the alveoli, or are we pushing air from the dead space into the alveoli?
So all I'm thinking is that when you inspire a volume of gas, say you've got 150 mils of anatomical dead space, that 150 mils isn't just like a block of air, that it's got varying flows in it, so that there will be some laminar flow with different velocities that enables it to go beyond the anatomical dead space and participate in some gas exchange. So it's not a static structure. You've got other factors that will mean that it's not just a uniform bulk of 150 mils. Yeah.
Cool. And sorry, one more question was which type of flow is better for purging? I didn't quite understand why turbulent flow will be better for purging, because I thought it is about flow.
Yeah, so if I think the reasoning that they're giving here is that if you have laminar flow, because you've got varying profiles of gas velocity, that you can imagine that, if you've got volatile stuck near the edges, then it's moving slower. So you're not getting a uniform purging of all your volatile. I think that's their argument there. So if you have turbulent flow, it's causing, looking at that little diagram C just on the screenshot on the slide there, you can imagine that because it's turbulent flow, it's causing a mixing of all of your gases, and ensuring that all of them are transferred on bulk out of your system, out of your lungs. And I think that's why that's their reasoning.
Okay, thanks.
Really good questions, guys. Thanks. So let's talk about this next section. Describe the factors that affect airway resistance and how airway resistance may be measured. Simon Leckenby, what do you reckon?
Yeah, hi. So I think that a definition of resistance would be a change in pressure over airflow.
Yep.
I think the normal values in an adult were 2 centimeters of water per liter per second.
Yeah, I'm probably about 0.5 to 1.5 as shown on that graph at, around FRC, but that sounds reasonable.
Right. And I think contrasting that to a neonate, you've got about 20 to 25 centimeters of water per liter per second.
Excellent. Always good to add a little, extra bit that's easy to add to give it context. That's great. Keep going.
So you've got the graphs there. So you can see that the airway resistance decreases with lung volume in the top graph. Mm-hmm. And then with the bottom graph, you can see that as the airway generation increases, the resistance generally decreases beyond the 5th generation.
Sounds good. And why is that?
So I believe, does that link back to Reynolds number? So I was expecting the shift to actually be later than that graph shows, to be honest with you, but does that link back to the flow type? So you've got more laminar flow the further down the airway generations you go, so you've got less resistance to flow.
Yeah, and also I think a big part of it is the fact that by the time you get down to your multiple airway generations, the combined radius is just incredibly huge, and so for given pressure, the radius is massive. So like we saw with the Hagman-Purcell equation, the fact that there's laminar flow, the fact that radius is combined so great that now you've got far less resistance.
Mm-hmm.
Yep. But keep going. So definition, normal values of the units, drawn a graph, and hopefully, this is well on the way to just passing a pretty standard question. Keep going.
Sure. And so the factors, so I went back to the Hagen-Purcell equation, and so I think the factors, radius is the main factor. So as you increase radius, the resistance reduces, and going back to what Andrew was saying about how in the small airways you have much less resistance to flow because all of the airways essentially act with a much greater cross-sectional surface area.
Mm-hmm. Yep.
Length, you can't really change length, but it is a factor there. It changes really with age and growth.
Yep. Sure.
The other factors, so you've got viscosity and density. So as viscosity and density increase, your resistance increases.
Mm-hmm.
And
I like to frame at the very top a laminar or turbulent flow, which is kind of goes without saying sometimes, but the fact that if it's laminar or turbulent flow will determine a lot of the other things that you talk about, namely viscosity, the density, and radius, and how that affects it. Keep going. Anything else you want to add? With radius, I then break it down into a few different factors, and this gets pretty clinical. So then, just to give, I feel like most of this, the meat of this is a lot of equations, and then pulling out equations and giving things like density and viscosity, and then the meat of it then can become just examples. Giving examples of turbulent and laminar flow, giving examples of density of gases and viscosity of gases, giving examples of the radius affecting factors. Do you have a format to talk about radius in different categories?
I must admit I don't.
I mean, just give it a go now. How could you divide up factors that affect radius?
Sorry, I'm not really sure where to start.
Yeah, that's right.
Classify an easy way to remember. I don't know if you use the same, but intraluminal or extraluminal.
Yeah, that's a good way.
Yes, you can apply that to clinical examples. So, for example, intraluminal, well, things like foreign bodies, edema, secretions, and then extraluminal extraluminal, you can talk about the concept of dynamic airway compression that could happen on forced expiration and then apply to patients with pathology, bronchoconstriction as well, or the low lung volumes.
Yeah, good. So, yeah, absolutely. Bronchial wall thickness stuff, infection, inflammation, neoplasms, external compression, especially dynamic airway compression or other extraluminal, mass lesions. And then particularly, important for airways is smooth muscle as well. So I've got that in a whole separate section because then that can be affected by your gases. CO2 affects your smooth muscle caliber, drugs, histamine release. And, that's worthwhile getting, pretty clinical and mentioning those because they can be mentioned pretty quickly as well. And then I've just got here, velocity of gas does affect it as well. Lung volumes, density of gas, respiratory rate. And then because we're anesthesia, and the tracheal tube of varying sizes will also change your airways resistance. Anything anyone else wanted to add with that?
I just had in humoral things as well. Like, I don't know, I just break it down to humoral, physical, and neural.
Yes.
But,
and that's pretty good. What did you say for humoral, physical, and neural?
So I had for humoral just beta 2 effects.
Mm-hmm.
Neural, I spoke about the parasympathetic. Then chemical, I added gastric acid and ammonia and sulfur dioxide.
Sure. And so whichever classification, just make sure that you don't use the one that best suits your purpose. Use the one that allows you to cover as many topics as possible, as many examples as possible. And then I also ended up using the one that I could then translate to another topic. Like this was then airways resistance factors was then a chunk of knowledge I could then insert into something else. For example, work of breathing. So whatever system you choose, just use the same system for each of your things to decrease the amount of memory load that you're going to have for the exam. So the final topic for today is then work of breathing. Kieran Bates, do you want to talk to me about this?
Sure.
Just give me a quick intro into work of breathing. Yeah.
Yeah, it's going to be pretty quick. I haven't covered this before, so I confess I opened up a textbook and had a look as well. So forgive me if it's pretty brief. So work of breathing is just the energy utilized for respiration, measured in joules as a function of overcoming, or as a product of pressure and volume, overcoming the restrictive and elastic forces of the chest wall and the lung and the airways.
Yeah, keep going, sorry.
Yeah, so normal values, I had no clue, but I've got in front of me that it's less than 2% of your total VO2. I have no clue the source on that, but maybe someone can help me out there.
I think that's straight from West. So 3 mils per minute of oxygen, less than 2% of metabolic rate, which is good.
And with regards to the graphs, yeah, look, I don't think I'd do a very good job of explaining or drawing them if I had to, as I've just seen them before.
Right. Before we get to that, actually, what do you, when I think of the factors that affect work of breathing, like you mentioned, there's elastic factors and tissue resistance, elastic factors and the non-elastic factors in inspiration and expiration. How do you conceptualize those? Like, how will you remember those?
I guess similar to what we're talking about with the intrapleural pressure graph, but the elastic recoil of the lung needs to be overcome. But on your side, you also have the chest wall expansion recoil and the elastic work there. So it's, I guess, I don't know if this is correct, but the difference between those.
And before you get onto that, I'm just going to tell people that this may be obvious to lots of people, but if it isn't, I think it's important to say that the good thing about, obviously there's a lot, incredible amount to remember about this exam. But if I think of the factors that are elastic and then non-elastic, the non-elastic factors are often just the airways resistance factors, which you've already learnt from airways resistance. And the elastic factors are often a combination of a lot of your compliance factors. So, the fact that you don't have to learn too much extra in work of breathing to get a very complete answer you can just chunk the knowledge you had from those other two sections and insert it. And that's kind of a hack for this, for this particular topic, if that makes any sense. Good. So in terms of the graph, let's say you haven't studied this recently, so that's absolutely fine. I want you just to talk me through this graph here, just the normal inspiratory, the work of breathing graph on inspiration expiration.
Sure. So this is graphing the pressure versus volume, which I'm not sure if this presents hysteresis or not in this kind of graph.
And don't even worry about hysteresis, so you don't have to even mention that when we're talking about this.
Okay. Yep. All right. So the work is the product of the pressure by the volume. So that will be the not necessarily the area under the curve, but the area within a zone on this graph. Would be my understanding looking at this.
Yep. Let's go to this. This is probably a better graph to explain it with. Yeah, tell me what each of these components are. Obviously, it's got it in the side, but just explain it to us.
Okay, so as you say, it has it in the side, but the total shading area, which would be the product of pressure volume, would be your total work. Inspiration would be on, I understand, one side between ABC, EA?
No.
ABC?
Like the if you completely shaded the whole thing A, B, C, D, A, everyone have a look at that. That's just your total work. You don't really have to worry, and that's on inspiration. And then break that up into elastic and non-elastic.
Okay, so I'm trying to sort of figure this out in my mind as I look through it for the first time. Sorry.
Yeah, no. Like, let's say, this is a good way of solidifying your knowledge. So might as well look at it first time now, and feel free to get everything wrong, get everything right. Who cares? Just take it as a learning point.
Yep. So I guess the elastic work, I can't actually see or figure out a difference between the overcoming work or on this graph between the elastic work. I don't know how I would define those, I'm afraid.
Yeah, that's right. So elastic work is pretty much just going to be the triangle. Imagine A, E. E is the point, going directly from A to C. A, E, C, D, A. That triangle is your elastic work. So then actually, so what it probably is worthwhile me quizzing someone then on this. Who studied this recently, or who wants to have a go?
I can give it a go. I did sort of cover this, but it's been a while.
Go for it.
But as you said, that triangle, so the area between A, C, D, and A is going to be the elastic work. And it is important because I think it is stored as potential energy that then is used for expiration. And that area between A, B, C, A is the resistive work, which is dissipated as heat. So that's, inspiration.
So and just for me, pictorially, so I think of a triangle as the elastic work, and I think of the little wedge, like a lemon wedge or whatever, that's my frictional resistance, that's my non-elastic work. Keep going, expiration.
Yeah, so that's right. So during expiration, then we have the area that, as we mentioned before, the triangle. So that's an area that, so F, so the area that goes from A, C, F, A. So that's essentially expiration showing resistive work, I think. Yeah.
Yeah, so that is what you're saying. So you've got all this stored up elastic work, which is the triangle, and then part of that's going to be used to overcome your airways resistance or your frictional resistance forces. And that's determined by A, C, F, A, the little wedge on the other side, inside the triangle.
Yeah, exactly. So because yeah, we have this energy stored, then it's sufficient, as you said, to overcome the resistive forces of expiration, and that's results in a passive expiration. And then we have the area that goes outside that, which is the triangle. So the area that goes from A, F, C to D, and that is I think that's just the resistive work that is done during expiration, and that's dissipated as heat, is what I remember. Is that right?
Yeah, that's simply, that's not, so the wedge inside that triangle overcomes your frictional resistance, but then all the rest of it is just dissipated as heat and kinetic energy of the gases.
Yeah.
And nothing is left at the end. So I mean, that's, you know, you can learn that. That's easy to learn. One thing that comes up in this is that some graphs have that point A not at the you know, the meeting of the x and y axis at 0.00. Sometimes they have it, you know, a little bit further along. And so that's simply, if you take just lung, if you take lung and chest wall, it meets at, you know, at the convergence of the x and y axes. But if you take it as just lung, then you see the extra point across. I try not to get too bogged down by this. I just draw it in the simplest way possible, because, you know, what are they really trying to get from you? It's an understanding of the fact that, you know, work of breathing comprises these two factors and has a stored potential factor as well. So let's look at then, if we look at this graph, just to get an idea of how, you know, where could this question go in a, you know, in an extended short answer question or in a viva. So on inspiration, the patient has increased airways resistance. What does A, B, C look like? And if you can imagine, you know, the elastic work is going to be the same, but if there's increased airways resistance, suddenly you're going to have a far larger wedge extending outwards, as you can see in I guess the third graph, just at the bottom there, where you've got a really large component. And likewise, if you have larger tidal volumes, that means you can have more elastic work done. So your triangle is going to be a lot bigger. So your elastic potential energy, elastic work is going to be a lot bigger as well. So Maria, what do you reckon? What's the implication of this with, say you've got really severe restrictive lung disease. Actually, let's start. Let's see you've got really bad bronchospasm. What does the curve look like, and what's the problem here?
So I think the main thing, so with bronchospasm, I think the graph is gonna change in terms that it's gonna, the loop is gonna be much wider, because we have, so in obstructive lung disease, the main problem is an increase in airway resistance. So both inspiratory and expiratory work need to increase to overcome that resistance. And that is basically represented by a wider loop in the pressure volume graph.
Yeah. So yeah, so if you have more airways resistance, then that wedge shape, so as you can see with this graph over here, you know, with this graph here, you know, let's say you get far more airways resistance. Think of on expiration, normally all the potential energy will be contained within here to overcome the extra airways resistance. But if you've got a really large, you know, large non-elastic component, that means that, you know, the energy required is going to extend past what you have available graphically, and so that's essentially the concept there.
Yeah.
Likewise, the implication for restrictive lung disease, you're just going to have far more work of breathing due to this triangle over here. Yeah, this triangle over here. And I can just imagine that that's the kind of vibe question that you'd have, where you'd have to separate these two parts out in a pathological context to then describe that.
So the gradient is reduced, but yeah, that's right. Yeah.
Does anyone have any questions about that? I've just got an extra point here that, you know, what happens when maximum ventilation is approached. So efficiency is about 10%. So the work of breathing efficiency is about 10%, but the efficiency falls to such a low level that, as you increase your maximum ventilation, the additional oxygen made available will be entirely consumed by the respiratory muscles. So, imagine your respiratory muscles doing what they're doing, and they're taking about 10% of the oxygen they deliver. But as you increase that, as you increase your ventilation, suddenly you're not actually getting any further gains, that your respiratory muscles will be taking all of the extra oxygen that they're able to deliver and, help to participate in gas exchange. So finally, I'll get someone now just to describe this graph. Yeah, Maria, do you want to go for this as well?
Oh my gosh, I haven't seen these graphs before.
Yeah, that's right. So, this will be, again, I try to chunk my knowledge. If I ever talk about work of breathing, I chuck in that first graph. I may chuck in the practical application in, restrictive or obstructive disease. And then I just, quickly draw this graph, which is, you can actually draw this pretty quickly once you know what you're looking for. But yeah, just what was it trying to say?
So, we're looking at, the impact of, I guess, respiratory rate in work of breathing. Because the graph is essentially, respiratory rate, work of breathing. So we're looking at the impact that the respiratory rate will have work on breathing. So we can see that if we increase the respiratory rate, we increase the resistive work, but decreases the elastic work. So I suppose to maintain a balance.
And that makes sense. So for a constant minute ventilation, if you're increasing your respiratory rate, your tidal volumes are going to be smaller. And if your tidal volume is smaller, that means that you're not stretching your lungs out to have to increase your elastic work. So that intuitively makes sense. So then in your pathological examples, what's happening with increased elastic resistance? So think of any kind of restrictive defect, and then increased airflow resistance. Think of chronic bronchitis.
Yeah, so then the work of breathing is going to increase. And the airflow, so the total work of breathing is going to increase when increase airflow resistance. Yeah, I suppose.
So why is the total work now better at high respiratory rates? So total work is best. So total work is lowest, and has a nadir or minimum point at about 15 breaths per minute on this graph for normal, and then it's higher for increased elastic resistance and lower for increased airflow resistance.
Lahiru,
yeah.
Look at it, and I'm going back to basics and not really thinking about the graph too much. But if you increase elastic resistance, so like something like pulmonary fibrosis or something like that, you're not going to be able to take the same tidal volume for that respiratory rate. So you'd need to have a higher respiratory rate to achieve the same volume, the same ventilation.
The ventilation, yeah, and you're right. So just imagining a really restrictive set of lungs, within like you just cannot, no matter how much you try, you cannot expand these lungs very far. That means that you'll just have to compensate with a higher flow rate. So you'd rather take on increased airflow work of breathing than take on the really bad restrictive chest wall that you've got. And so it just makes sense that you would have to just breathe faster. Habit airflow resistance.
Can I just on that note, earlier you asked me a question about how respiratory rate affects dynamic compliance, and I tried to tie it into work of breathing, but dynamic compliance is compliance of your lung chest wall plus the added effect of resistance. Am I going off track here a little bit? But say like with someone who has poor, say, chest wall compliance.
Yep.
Like as in depending on, because dynamic compliance includes both compliance of the lung and the chest wall and airway resistance, it will change depending on respiratory rate, just as work of breathing here changes, because it's effectively the energy you require to expand the lung.
So if you, I think I agree with your statement there. So dynamic compliance will increase because of your increased rest rate.
Just like when we were talking about dynamic compliance earlier, you asked me, how does dynamic compliance change if respiratory rate increases? And I said it depends on the chest wall, and it depends on whether you've got a restrictive or obstructive problem. And the answer we ended up settling on was that dynamic compliance increases with respiratory rate. But what I'm saying is, with someone who has airflow resistance, so therefore the major contributor to their increased worse dynamic compliance is airway resistance, not poor lung compliance.
Yes.
Having a reduced respiratory rate will actually improve that. Hence why people with asthma breathe slowly with big tidal volumes. Does that kind of...
Look, I get what you're saying, and I think I'm trying to keep the concepts separate just to aid the most seamless construction of a SAQ answer. But can we have a chat about this afterwards, though?
Yeah, of course. Sorry, I didn't mean to confuse.
Yeah. So likewise with increased airflow resistance, increased airflow resistance. Imagine that chronic bronchitis patient that you'd rather have, really large tidal volumes to take on the elastic component, because the elastic component is far better for this patient to take on than trying to overcome airflow resistance, because now you've got a smaller radius, hence your respiratory rate is lower. Yeah, so that's the end of this first section. So just to kind of outline what we covered, we did a few exercises with discussing the chest, structure of the chest wall and the diaphragm, and the implications of respiratory mechanics, the lower airways, just a brief anatomy of the pulmonary and bronchial circulations, and just some interesting facts about those, control of ventilation, surfactant, compliance, fast and slow alveoli and the concept of time constants, elastic properties of the chest wall, explaining the pleural pressure and its significance, gas flow and airway resistance, as well as closing capacity, and then work of breathing and lung mechanics in these common disease states. So what I'll get you guys to do is I'll send you guys an email with the syllabus for next time. Actually, here it is. Do you guys want to take a quick screenshot or photo of that? That's your that's your syllabus for next time. And so what I'm going to ask people next time is to demonstrate, maybe even draw on their own screen share, how to measure lung volumes, how to measure dead space, applying the Bohr equation. And we'll go through the oxygen cascade, which is again a very good diagram to be able to draw. Diffusion capacity, that'll be an SAQ type thing. BQ matching, that will be SAQ type thing. And then methods to measure VQ perfusion inequalities. So yeah, that's what we'll do for next time. Again, this is the first time I've done this on Zoom. Please let me know if there's any suggestions to make this run as best as it can. And overall, just know that this exam will be passed based on not the minutiae. It will be passed based on these big picture things, and just having your structures and your exam technique down, and then all the other little detail just keep adding on as you do it. Just real small gains through each time you do these questions. And with the physical distancing and restrictions, what else do you have to do anyway, right? So yeah, I'll go from there, and thanks very much for your time, guys. Any questions, please email me.